Good afternoon, everybody. I'm Kathy Troisi. I'm on the faculty here at UT Health Houston School of Public Health, and also working with TEPHI, the Texas Epidemic Public Health Institute. And welcome to our grand rounds today, where we have Dr. Thomas Doker talking about melioidosis. And is this a concern in Texas? But before we get started, if you could advance the slide, let me tell you a little bit about TEPHI, just in case you're not familiar with us. This is a Texas state institution that's housed here at UT Health. This is our mission statement, to keep Texans safe and the economy strong by strengthening capacity and resiliency so that we can respond to future infectious disease outbreaks, which unfortunately we know will be occurring. Next slide, please. So we, as I mentioned, are housed within UT Health, but we have a lot of relationships with governmental agencies, non-governmental, professional associations, business entities, academic institutions, and then other community organizations. So one of the things that we provide is training to help, particularly folks who are working in public health, but these courses are available to everybody. They are asynchronous and free of charge. We have a certificate program consisting of those 4 courses you see there, and then a capstone top exercise. You can get CE credits for a variety of disciplines. And as I mentioned, no cost for Texas residents. So there's a QR code there, or we will be showing you our website address a lot of times. So you can also just go there to register, just to see what these courses are about. In addition to this certificate program, we have some mini courses in specialized areas. These are 1 to 3 hours, again, totally asynchronous, online, and free of charge for Texas residents, and CE credits are available. We have 2 that have just come online, the Introduction to Survey Design and talking about sensitive topics in public health. So here are some ways you can connect with us, but if you go to tephi.texas.gov, you can find all of this information. And then just some housekeeping items for this webinar. If you would like to have a live transcript, you can get closed captioning by clicking live transcript. There's the chat to answer, or to pose questions, rather, comments, etc. You will be getting a survey that we really appreciate you filling out so that we can make these useful and improve them. The webinar is being recorded. It will be emailed out to everyone who's registered for the course in about a week. And again, if you go to our website, you can find previous Grand Round recordings on our YouTube channel. All right, so let's get down to business. Our speaker today is Dr. Thomas Doker. He is a native Texan. He went to the University of Georgia for his undergraduate and his veterinary training. And then he also has a Master's of Public Health from Georgia State University. He is he's board certified in veterinary preventive medicine and EPI, and he was an EIS, an Epidemic Intelligence Service officer at CDC from 2012 to 2014. And he's a member of the Air Force. You might be able to tell that from the picture. And he has been deployed as Deputy Squadron Commander and a DoD Intelligence Agency Division Chief, as well as being deployed as a division-level civil affairs vet in Iraq and as a preventive aerospace medicine team commander in the Middle East. So he is going to be speaking to us today about melioidosis. And welcome. We're so glad to have you, Dr. Doker.
Hello, everybody. As she said, my name's Tom Doker, and Notice that I've never been stationed in any of the tropics, but we're going to talk about a tropical disease today. I would like to discuss a few important basic facts about melioidosis, the disease and its epidemiology, and how this tropical disease has found its way to Texas. In addition, I would like to discuss the environmental possibilities of Burkholderia pseudomallei becoming endemic to Texas. Next slide, please. Standard disclaimer, the views expressed are my own and do not necessarily reflect the views or policies of the U.S. Air Force. Thank you. Okay, a little about basic information about melioidosis disease. It's caused by infection with the gram-negative bacillus Burkholderia pseudomallei, which is hard to say, so from now on I'm going to say B. pseudomallei. The figure shows the bacilli located within lung abscesses using immunohistochemistry or IHC staining. Case fatality rates have a wide range depending on disease manifestation, how it presents, promptness of diagnosis, and appropriateness of treatment. Or is the patient started on the correct treatment? Depending on the completion of effective treatment regimens, relapses with the original bacterial strain are not uncommon, as well as reinfections with different strains when you live in endemic areas. Organisms classified as Tier 1 overlap select agents, such as B. pseudomallei, present the highest risk of deliberate misuse. Those with the most significant potential for mass casualties or devastating effects to the economy, critical infrastructure, or public confidence. Characteristics of melioidosis that increase those risks are related to its potential inhalation route of infection and the prompt diagnosis and specialized antibiotic treatment that is required to prevent serious disease and death. The other common routes of transmission are percutaneous contact with or ingested of infected soil or water. However, a Mississippi case was reported in 1975 that was associated with probable venereal transmission from a Vietnam veteran to his wife. And I got an email from Dr. Joe McCormick that reminded me of that case, so I appreciate that reminder. I thought that was appropriate. And the highest risk factor of disease manifestation is associated with diabetes, especially those cases with a history of poor glucose control. And another significant risk factor is chronic renal disease. Next slide, please. The good news is that most cases of melioidosis are subclinical, but the incubation period is 1 to 21 days, pretty standard, and a median of 9 days. However, 85% of the clinical cases present as acute cases with life-threatening sepsis, along with pneumonia or abscessation. The diagram shows the numerous places where abscessation can occur, from the brain to other soft tissue locations throughout the body, often in conjunction with septicemia. Only about 11% of clinical cases present as chronic cases, and those are defined as ongoing illness of over 2 months. And then even less than 5% represent cases of activation from latent disease. The most famous case of that I was familiar with, it was after a supposed introduction 62 years prior. And we're going to go over that case some more as we go through the presentation because it was diagnosed in Texas. As mentioned before, antibiotics typically used as initial treatment choices in most U.S. ERs for community-acquired pneumonia plus or minus sepsis are not effective for melioidosis. Also, it is important to repeat that a better prognosis is associated with early diagnosis followed by appropriate treatment. Intravenous ceftazidime or meropenem, and forgive my southern accent on those, but that's the best I can do, are recommended for a minimum of 2 weeks, followed by an eradication treatment regimen using oral trimethoprim sulfa or amoxicillin clavicinic acid for 3 to 6 months to prevent those relapses. Next slide, please. Okay, so laboratory diagnosis. How do we diagnose this? It's by culture. It's the gold standard for B. pseudomallei. Screening labs from automated systems such as Vitech can be effective for diagnosis when trusted by clinicians. We investigated a fatal, you heard earlier, I did a epidemic intelligence service fellowship, and this was one of the cases we worked. We investigated a fatal melioidosis case in Ohio that was initially diagnosed as a bacillus because the microbiologist noted that the patient history did not reflect any travel south of Kentucky. So it was hard for him to believe that this was truly a Burkholderia. And then we'll have some more on that case later in the presentation. PCR is often used on environmental samples and for serology, indirect hemagglutination assays, or IHAs, have been used to test for exposure. With 1 to 40 typically used as evidence of prior exposure in humans, and 1 to 320 in non-human primates. Melioidosis can present with numerous non-specific signs and symptoms, and thus has been referred to as the great mimicker, as evidenced by that long list of clinical manifestations on the slide. As you can see, respiratory and cardiovascular, meaning bacteremia, are the primary manifestations. But of note, in Thailand, 30% of the children present with parotid abscesses. So it's a wide range, and that's why it's called the great mimicker. Next slide, please. Okay, enough on some basics of melioidosis disease. Let's get to the fun part, epidemiology. Wersinga et al. In 2018 published a map on the slide showing estimated mortality and reported cases throughout the world. As you can see, as represented by the countries colored in orange, Southeast Asia and Nigeria have the highest number of estimated fatalities, with most cases occurring in Southeast Asia and Australia, as evidenced by the size of the blue circles. The global burden of disease is estimated at approximately 165,000 cases, with about 89,000 deaths each year. This estimation placed the global impact of dying from melioidosis between that estimated from measles, which is appropriate, as we're discussing the diseases in Texas right now, and leptospirosis. In the Western Hemisphere, most cases and deaths are found in Mexico and Brazil, with U.S. cases occurring in primarily in Puerto Rico and the Virgin Islands. We will explore the risk in the continental U.S., especially associated with Mississippi and Texas, later in the presentation. I will focus primarily on human infections, but infections in other species are important to note when exploring the epidemiology of this disease. Okay, next slide. 2016, Melioidosis et al. Published a paper describing the predicted environmental suitability for B. pseudomallei persistence based on soil characteristics, precipitation, land surface temperature, and vegetation moisture index. Of note, red areas denote high environmental suitability, and green is low, with yellow in between. I remember reading this article back then and saying, really? Texas and Florida, we got to worry about endemicity of melioidosis, of Burkholderia? Next slide, please. Well, let's take a closer look at Texas. South Texas showed a high to moderate environmental suitability for B. pseudomallei. As you can see, one case was diagnosed in southern Arizona in 1999. Research by an EIS team failed to find a source of infection in that case. And then in 2004 and 2018, 2 different cases of melioidosis were diagnosed in the southern Texas county of Atascosa, found within the red and yellow areas of environmental suitability. Again, the sources of infection were not found for either. And then a case was diagnosed in Grayson County in 2021 in northern Texas, located in an area of low environmental suitability. I apologize, I got 2 on the slide, but it was only a single case. Now, were any of these cases related? Let's move to the next slide. Okay, for that, let's review a dendrogram for the characterization of the B. pseudomallei strains isolated from the Arizona and the 2 Atascosa County cases, along with the Grayson County case. As you can see, the 2 Atascosa County cases were similar to the Arizona case strain, with the closest relatives found in South America. Other related strains were from Mexico or the Caribbean. Remember, I mentioned an earlier case that was associated with the 62-year incubation period resulting from exposures while serving in World War II in Southeast Asia. That was the 2004 Texas isolate depicted above or on the slide, which is not related to strains from Southeast Asia, but rather to strains from the Americas. The source of this patient's infection remains unknown. However, due to the strain grouping with 2 other southwestern isolates, it has been suggested that B. pseudomallei might be present in the environment and represent a new clade endemic to the continental US. As for the Grayson County case, that one was associated with a multi-state outbreak strain linked to a contaminated aromatherapy spray product. And I will cover that outbreak later in the presentation. Okay. Okay, so let's remember, I mentioned earlier an Ohio case that we investigated when I was with DIS that was initially misdiagnosed as a bacillus and thus did not receive early appropriate treatment for melioidosis. Again, this patient had no reported travel south of Kentucky, but the B. pseudomallei strain was linked to strains from Southeast Asia. We procured serology samples from the patient's extensive family who lived with him along with all his pets, and he had quite a few pets too. We thought it important to make sure no other family members were showing titers that may represent recent exposure to B. pseudomallei. All the IHAs were negative. In addition, we tested numerous environmental samples, including potting plant soil, aquarium water, personal care products, and outdoor soil samples. All these samples were PCR and culture negative. Thus, we also were unable to determine a source of infection for this patient. Although unsuccessful in this case, and in the previous discussed Arizona case, research then has been able to determine the source associated with more recent US cases, and we will get to those shortly. One way B. pseudomallei has been introduced to the US is through imported non-human primates from Southeast Asia. Prior to this 2012 report, 14 cases of melioidosis were diagnosed in non-human primates since 1963, including animals located in Southeast Asia, Europe, and the US. 7 of the US cases were reported from animals. All those were also from Southeast Asia, and that was since 1970. The case seen in an imported pigtail macaque from Indonesia at the Centers for Disease Control and Prevention Laboratory in Atlanta was identified after it had completed its quarantine at a CDC-registered import facility. Upon physical examination after its initial acclimatization period, a subcutaneous abscess was noted overlying the right tibial crest, along with the right inguinal lymphadenopathy. A bacterial swab of the lesion revealed a B. pseudomallei strain type associated with Southeast Asia, where the animal was from. The initial abscess responded to treatment over the course of 3 months, However, 2 months after completing treatment, the animal's condition declined rapidly and presented with cranial lesions. The macaque did not respond to renewed intensive care and died 2 days later. The slide shows the necropsy findings showing numerous areas of necrosis with hemorrhage throughout the brainstem. Further diagnostics confirmed the diagnosis of B. pseudomallei in the brainstem, spinal meninges, lung, and liver. This case represents several of the presentations that can be seen with melioidosis. What are some additional sources of infection in the U.S.? We'll move to the next slide. In 2007 and again in 2012, 2 pet iguanas in California were diagnosed with the B. pseudomallei strain that matched the earlier Arizona case strain. Interesting enough, were reported and that case had a reported travel to Costa Rica. PCR testing of one of the case's water bowl was also positive for B. pseudomallei, representing a risk to the owner. Since most imported green iguanas are from Central America at that time, the authors recommended increased awareness from owners, sellers, veterinarians, and laboratory staff when dealing with abscesses seen in green iguanas. This next report and a review of 120 melioidosis cases reported in the Americas from 1947 to 2015, 95 cases were classified as resulting from likely exposures within the Americas, primarily from Brazil, El Salvador, and Colombia. And 25 of the cases had likely exposures from outside the Americas, primarily from Thailand, traveled to Thailand, Vietnam, and the Philippines. Of the 47 cases that reported potential exposure sources, 20% reported soil only, 17% both soil and water, 7% water only, and 2% animals. This is to be expected as B. pseudomallei is classified as a saprophyte, which is an environmental pathogen. So most exposures in endemic areas are expected to be from soil and water. Okay, next slide. However, as this 2016 case proves, exposures associated with infected animals remain important. A single adopted dog from Thailand to New York State resulted in potential exposures to 27 individuals. Most were from exposure to the dog's urine as a result from caring for the disabled animals, as he was unable to walk and thus wore a diaper, which took regular care. Of the 27 contacts, 11 were deemed as no risk, 3 were considered low risk exposures at the dog's residence, 6 at low risk at the animal shelter, and 16 others were deemed at risk at the veterinary hospital. 14 of those veterinary contacts were deemed as low risk, but 2 with pre-existing chronic medical conditions were deemed high risk. Of the 16, 6 agreed to 3 weeks of symptom monitoring, 3 to baseline and sequential serology for B. pseudomallei, and 1 high-risk contact chose a 3-week course of prophylactic trimethoprim sulfa. None of the 27 total contacts developed symptoms or later tested positive. The one serology that went from 120 to 140 was considered indeterminate and non-actionable. This case highlights how a single infected animal with melioidosis can lead to multiple exposures at several locations. Okay, well, let's return to a case, Texas case now. Remember the 2018 Atascosa County case we discussed earlier? The B. pseudomallei strain was related to the 1999 Arizona case and the 2004 Atascosa County, Texas case seen in that World War II vet. This case presented with pneumonia, and his most relevant recent travel history was to Mexico, which was 30 years previously. 56 environmental samples of soil, water, and biofilms were taken from the patient's home and property, and all were negative. 7 contacts were identified as low risk and agreed to symptom monitoring for 3 weeks. In addition, serology samples pulled at 1, 2, 4, and 6 weeks were all negative. The images show the progressive changes in the patient's cutaneous chest wound resulting from his infection. So as mentioned, there was concern that this case may have resulted from exposure to a North America strain that had established itself in Atascosa County. However, environmental sampling was unable to substantiate that hypothesis. So, what are some additional potential sources for exposure to B. pseudomallei in the continental US? Next slide, please. This was an interesting case in 2019 from Maryland. After purchasing 2 aquariums with fish in July of that year, the 56-year-old woman reached into tank B with her bare hands and arms in August, probably cleaning the tank. But shortly thereafter, all the fish in tank B died. The case patient had discontinued her long-term immunosuppressive medications at around the same time in August. Later in September, she presented with fever, cough, and chest pain. She had a history of diabetes, and as you remember, that is one of the biggest risk factors for developing melioidosis. She also reported no international travel. She was hospitalized and started on antimicrobials. Blood cultures led to a presumptive diagnosis of B. pseudomallei, and the patient's treatment was changed from ceftriaxone and azithromycin to IV meropenem. After her symptoms started resolving, she was discharged with IV meropenem, and a lab sample was sent to the Virginia Laboratory Response Network lab, which confirmed a positive B. pseudomallei result. The CDC determined that the sample strain was related to those from Southeast Asia. Meanwhile, the patient had bought some more fish to replace those that had died in tank B, but unfortunately, all of those fish had died too. So in November, a Maryland investigation team visited the home of the patient to collect environmental samples. Samples were collected from the aquariums, household faucets, soil from potted plants in the yard, beauty products, and vaping products. 3 samples from the water collected from tank B and from an associated tank gravel sample were positive for the same pseudomallei strain as the patient's. The Maryland Department of Health decontaminated and removed tank B, and the patient later recovered. Next slide, please. Now, back to the 2021 multi-state outbreak identified in Kansas, Minnesota, Georgia, and Grayson County, Texas. None of the cases reported international travel, but all did report that they had used the same brand of aromatherapy spray imported from India. Subsequent strain typing of samples from all 4 patients, along with an aromatherapy sample from the 4th case in Georgia, were all the same strain associated with South Asia. Once again, this shows the value of thorough investigations and laboratory sampling to find outbreaks and to determine the sources, with strain typing often providing the key link. Next slide, please. Okay, well, we keep circling back to those 2 cases in Atascosa County, Texas. Turns out they only live 7 kilometers apart. So a study was undertaken in 2019 to see if the pathogen was present in the suspected local environment. 370 environmental samples were collected from near and around each of the 2 residencies, along with those sites closest to Atascosa County, showing highly suitable environments as determined by ecological niche modeling, and they were all negative for B. pseudomallei DNA. Panel A shows the similar modeling results seen earlier in slides 7 and 8 of the presentation. And panels B and C show the highly suitable ecological niche modeling results at the state and then at a zoomed in view, including Atascosa County. The white dots show the actual sampling sites in the surrounding area. And panel D just highlights the cropland data associated with the same area as panel C. The authors concluded from an extensive sampling study that the overall risk of obtaining melioidosis was low within the continental US. Do we need to be concerned then about endemicity of the pathogen in conus? Let's go to the next slide and see. Here we go. Well, let's move to the nearby state of Mississippi and the investigation of 3 melioidosis cases there from 2020, 2022, and 2023. All who lived within a 20-mile radius in the same Gulf Coast county. All 3 patients reported with pneumonia and sepsis and had no relevant travel history to endemic countries. 3 soil and water samples collected from the 2020 patient residents, and all 3 patient samples were genetically similar and annotated as Gulf Coast strain 2020. These findings indicate that melioidosis may be endemic to the Mississippi Gulf Coast and resulted in a CDC Health Alert Network or HAN advisory in July of 2022. Well, possibly endemic in Mississippi. How about Texas? Let's go to the next slide. Well, I keep asking you to remember, but remember the Texas May 2021 aromatherapy outbreak case identified in Grayson County that we have discussed several times now? Well, it turns out the family had a pet raccoon that had broken a bottle of the implicated aromatherapy spray and had walked through the spillage. The animal developed acute neurologic symptoms 2 weeks later and subsequently died after 2 days of symptoms. So neuro and a raccoon, what else do we have to worry about? Well, anyway, the owners chose to bury the animal that April prior to any of the residents having developed symptoms. Later in 2022, it was determined that even though Grayson County fell in a low environmental suitability niche, sampling of the burial site was indicated to determine if the raccoon had perhaps died from the same aromatherapy outbreak, B. pseudomallei strain, and if so, to detect any evidence of environmental contamination. So 32 environmental samples were collected from the soil, tree root fragments in the area, and water from a stream downhill from the site, as depicted in the diagram. Sample collection was followed by disinfection of the burial site using sodium hypochlorite diluted 1:3 with water. 2 swabs from the intraorbital tissue of the raccoon carcass was PCR positive for B. pseudomallei, but was culture negative. So the most likely cause of death was determined to be from melioidosis, but without a positive culture, strain typing was unable to be accomplished to prove a link to the aromatherapy outbreak strain. But comfortably, it showed that it was having difficulty growing in that environment, which matches the low suitability index. All other tissue and environmental samples were negative. So once again, no soil contamination was found. And as of now, no B. pseudomallei has ever been isolated from Texas soil or water. Next slide, please. So we've covered a lot of melioidosis epidemiology in the US and with a concentration on case investigations in Texas. After the CDC HAN advisory regarding the probable endemicity of B. pseudomallei in Mississippi's Gulf Coast, the Council of State and Territorial Epidemiologists approved the addition of melioidosis as a nationally notifiable disease. While I was at EIS, we had presented an appeal for the same at 2012's meeting, but now 10 years later, CSTE has agreed. The key to remember about this requirement, all positive results should immediately lead to notification of your local and state public health agencies, and all isolates should be referred to the laboratory local response network for confirmation and strain typing. The CSTE highlighted in their reasoning that the genomic analysis of isolates collected from 2 Texas and 2 Mississippi patients with no recent travel history indicate the potential endemicity in North America. Go Texas, Mississippi. Next slide, please. Okay, so I've referred several times to the importance and relevance of strain typing positive B pseudomallei cultures. Older studies referred to multi-locus sequence typing, or MLST, but later internal transcriber spacer, or ITS typing, has proven to demonstrate more geographic resolution. Earlier studies using MLST indicated that B pseudomallei most likely originated on the Australian continent because of the high level of genetic diversity seen in isolates from this region. Subsequent studies using ITS indicate that the organism was most likely introduced from Australia to Southeast Asia, and then from there to Africa. And then Africa most likely became the source for B pseudomallei in the Western Hemisphere, potentially associated with transfer to the Americas by the slave trade. So the association of clades with geographic origin are a useful tool when investigating cases of melioidosis in patients without a clear exposure history. As noted, we have discussed the multi-state outbreak associated with the product from India, and several environmental studies where phylogeography provided key clues. Finally, to close the 2004 Texas veteran case, did it truly represent a 62-year incubation period, or did a subsequent exposure elsewhere lead to the patient's infection? He was captured by the Japanese in World War II and was interned in various camps in Southeast Asia as a prisoner of war. Well, looking at its ITS type, type G, which is more associated with isolates from Guatemala, Panama, and Peru, that suggests that his infection might not have been acquired in the Pacific theater during World War II. Going back to the Ohio case, by my notes here, case we investigated, that strain has since been ITS typed as type CE, associated specifically with Thailand. Next slide. We have covered infections seen in green iguanas, non-human primates, freshwater fish, raccoons, and dogs, showing a wide diversity of potentially infected species. This chart developed by the CDC shows many of the other species susceptible to melioidosis disease. In the slide, we can see the range of symptoms that can be seen in the various species. Again, reinforcing the moniker the great mimicker for melioidosis. Sheep and goats seem to be the most susceptible, thus I put them in red. Camelids and horses, moderately so, in blue. And then the rest in green. Cattle, pigs, birds, dogs, and cats seem to be the least susceptible to melioidosis infections. Transmission in animals is through the same mechanisms as seen in humans, from contaminated soil and water exposure through wound sites, ingestion, or inhalation. Next slide, please. We have covered many aspects of melioidosis prevention and response, but it is recommended that those with higher medical risk factors, such as we have noted, especially diabetes, should avoid exposure to contaminated soil and water and protect wound sites whenever they visit potentially endemic areas, especially during and after extreme rainstorm or water events. Occupational workers at higher risk include agricultural and healthcare workers who are recommended to take additional precautions. Once potential exposures have been identified, it is recommended that each patient be interviewed for possible medical risk factors to help determine the risk to that patient. Those with no underlying conditions may more safely be determined as lower risk contacts, where measures such as twice daily symptom monitoring for 3 weeks may suffice. However, all contacts can be offered serial serology sampling using IHAs to help determine potential exposures. And of course, those with underlying conditions should be advised to consider post-exposure prophylaxis with antimicrobials. To help protect owners when animal cases are identified, standard isolation measures of the patients and quarantine of the premises of potential contacts can limit additional cases. And of course, standard biosecurity, decontamination, and PPE measures are helpful to also limit spread. As an adjunct to patient and contact measures, measures to limit environmental contamination are called for, especially in areas of the U.S. where ecological niche modeling demonstrates higher risk of pathogen environmental suitability, such as South Texas. Disposal of affected dead animals should be coordinated with your state veterinarian. Controlling the spilling of bodily fluids to the up to when you carcass disposal, and appropriate use of 1% sodium hypochlorite bleach disinfection solutions can minimize the chances of environmental contamination. Control the spillage, up to when the animal is buried with B. pseudomallei. As of the present, there is no approved vaccine, but there is a steering group on melioidosis vaccine development exploring possible candidates using standardized animal models. With B. pseudomallei identified as a tier 1 overlap agent, a vaccine providing protection against naturally acquired infections and for potential bioterrorism use would be the most useful. Leading candidates include those depicted in the diagram, which include outer membrane vesicle, live attenuated, glycoconjugate, and nanoparticle vaccines. Of course, the best candidates should have multivalent properties with affinity for numerous bacterial components. And vaccines that elicit both antibody protection and CD4 and 8 cell responses would most likely be most efficacious. Finally, what is the future of melioidosis, especially in Texas? As One Health practitioners, we are all cognizant of the drivers behind increasing endemicity of B. pseudomallei, including those shown in the illustration, such as due to the epidemiological transitions associated with increasing rates of diabetes and plus or minus alcoholism, zoonotic hazards such as those associated with global trade and travel, changing levels of rainfall, and increasing risk of extreme weather. Now, you see one word, I had to look it up, the word anthracene. Well, it turns out that is a type of soil that has been formed or heavily modified due to long-term human activity, such as that seen with irrigation, addition of organic waste, and wet field cultivation practices used to create paddy fields, such as needed for rice production. And rice production is an especially associated with melioidosis cases throughout Southeast Asia. Bottom line is that we all have to work together using a One Health approach, using monitoring and surveillance, followed by the field investigations of any detected cases. These should be led by One Health interdisciplinary and interagency teams to ensure we continue to keep a pulse on the increase of any potential B. pseudomallei endemicity in the U.S. and of course within Texas. Okay, well, thanks so much for your attention. I know I've done a lot of talking, and I will pause now for any questions. If we don't have time, or if you wish to reach out later, please feel free to use my personal email address above. Now, we had several questions submitted early, and I hope I addressed those in the presentation. If not, please ask now.
You want to address that one, or while people are putting their questions in the chat, I have a couple for you.
Okay. The one, I think most of them were already included in the presentation, but there was one, is there a organized system of surveillance in animals? Well, there really isn't in humans either. So once you pick up the bacteria, or diagnose the bacteria, then it's reportable either, by the clinician and by the laboratory. But there's really not an active, hey, for all community acquired pneumonias, we're going to test for this. No, we're not that. It's only resulting from positively diagnosed cases.
Great. Well, let me ask you some of mine. I don't think you specifically said this. There's no human-to-human transmission, correct?
That is true. I apologize for leaving that out. I focus a lot on animals, but has been no cases except that one venereal disease case that Dr. Joe sent us about. So that was human to human.
Oh yeah. And you mentioned that diabetes is a risk factor for infection. I'm not sure if you're aware, but on the border of Texas, the southern border, there are it's a high prevalence of diabetes. Do you think that could be dangerous then in terms of melioidosis cases occurring?
It's, of course, diabetes isn't good to have, period, right? But and it's almost every case you heard me speak of, today in humans was related to diabetes. And we think that the disease can remain latent and might not even manifest until maybe your A1C gets out of control, and those kind of symptoms. And then the bacteria is able to come out and manifest clinical disease. So no, that's not a good thing to have possible in endemic areas. But it does seem like it still needs to be introduced into the area. Maybe it's not there right now, but if we can prevent, all the introductions we can, maybe we won't get into like having leprosy in our armadillos, right?
Another question. So the vaccine you mentioned, that's for animals, correct? Not for humans?
No, it would be for humans. If they're
looking it would be for humans.
It's primarily for humans. And because you see the prevalence in Southeast Asia and Northern Australia with that higher risk, and especially if you're occupational, maybe you're a rice worker, right? You work out in the fields. So there's certain folks that would definitely benefit from that. And of course, that's what we would like to have in SNS, Strategic National Stockpile, right? If we had a bioterrorism event.
Yeah. And let me read you questions from the chat. Thank you for a wonderful presentation. It sounds like there isn't routine screening at ports of entry. Is this something that would be beneficial to implement for certain species coming from high-risk areas? And then an addendum to that question, is there a way to screen for B. melioidosis?
Well, you can't screen. We did a study in Puerto Rico where we had a fatal case of melioidosis diagnosed, and we did a serology study of the neighborhood, and it was amazing how many people. We didn't have a single refusal there. I know I could do that in Texas or here in Louisiana. The door would be slammed in your face. But anyway, 26% seropositivity. They were over with IHA. It was over 1 to 40. So from there, that guided us to go in there and look in the soil in that environment, and we were able to find it growing in the Puerto Rico soil. So the serology is the most likely recommended, and of course, an investigation of any abscessation or clinical illness, standard things you look for anyway at a quarantine station, right? But I did mention that they have suspected, that 1 to 320 above that may represent a prior exposure in non-human primates. So I don't think they regularly do that, and I'm not sure They may now, but I would have to get back to you to see if they do that now. But that would make a little bit of sense to me.
Another question for you. Any documentation showing how many animal cases of B. pseudomallei have been identified in the U.S.?
I haven't seen a study that tied those together, but I tried to pull up all the ones since 2012 that have been published. So we got through, especially for CONUS, and so this presentation shows a pretty good representation. Is it complete? I cannot answer that.
This is related to the other question, the first question, but a little bit different. Should this disease be considered for routine screening for those that are newly immigrated to the U.S.? I assume from areas where it's an issue.
No, and as I said, most cases the subclinical will never be a problem. So you could get positive titer. How are you going to react, right? So no, that's not recommended, and it's probably the same for why they may not do non-human primates, or most cases are going to be subclinical and never represent a risk to others. But and all these things cost money, right? And we have scarce resources in public health. So I would be surprised if we ever had a recommendation like that, unless it's something cheap and easy, a tricorder or something where we just go beep.
If only. Another question. Thank you for the presentation. You mentioned rice paddy fields that were good for growing the bacterium. I'm curious if grass growing fields are susceptible as well, because Grayson County, the county that had one case in Texas, has a large number of grass growing fields to sell.
The biggest risk with the rice fields is the level of water. We know the flooded fields, and that wading through there, planting the crops, and a lot of skin exposure with that. With the landscaping grass, that you may have irrigation. Well, you do have irrigation and maybe even organic waste. But those, most of that, there's not a ton of wading or, exposure to that, and a lot of equipment riding. But I guess if it gets in that soil, it could be a concern, but probably not as high as working in flooded fields.
All right. Should routine environmental sampling occur in areas with high cases of diabetes?
No, then again, it's hard to, we have no indications the pathogen's already here. It has most likely been introduced in a few places, as we proved there in Mississippi. Where that came from originally, not sure, but the strain typing can get us to the region where it came from, but what was patient X, number one that came in and brought it in, it's hard to tell. So no, I don't think just widespread testing would be. Well, look at all the sampling we did in Texas. What was that, 370 samples, and we did find it in highly suitable areas. So I think it'd be tough to find in that manner, and I probably link it to any cases that are found in animals and or humans, and would be the best way to use that type of testing.
And the last question I have so far, what factors triggered the reactivation after a 62-year incubation period? Okay, and can I just add, is that the longest incubation period for anything?
Well, it was touted in all the papers, and I actually did too in my earlier papers. But as we saw today in this presentation, the strain type was linked to the Americas and not Southeast Asia. So most likely is not a 62-year-old. We did speak to the doctors that diagnosed that. It was military doctors. And there sounds like, and we weren't able to talk with the family, but there could have been some travel to the Caribbean, and most likely had a diabetes manifestation, and that he was having trouble controlling at that age. So that's probably why he manifested eventually. And it could have been most likely was a much more recent exposure in the Americas, probably in the Caribbean when he went on a cruise, a probable cruise. We're not sure about that.
I'm not seeing anything else, but I have one last question of personal interest to me because my daughter and her husband are supposed to be moving to Thailand, to Bangkok, for 3 years. So you've mentioned risk for certain occupations, which they will not be engaged in. Is there any risk, for people not in those occupations?
Well, there's always risk, but I would say it's low unless they have diabetes that's not controlled well. That is the number one risk factor. Renal disease has been associated with cava consumption, different. There's other things that's been associated with it, but the biggest association is diabetes. But but you're seeing it we're seeing it in kids, with the parotid abscesses in Thailand, and I doubt if they're already a diabetic. So there are other exposures that can be problematic. And the ones in the recent hurricane events in Puerto Rico, we had a few cases diagnosed in the folks there from the soil being aerosolized and along with the organism in heavy storms.
Yeah, my grandchildren are going too. All right, we'll talk offline about prevention. Let's see. Is there a difference? Wait, I gotta scroll it down. Now, 1 second. Is there a difference between type 2 and type 1 diabetes as a risk factor?
No, I think the biggest thing is not that I've seen. It just depends on how well it's controlled. It seems to be the biggest risk factor. If they're able to control it well, it doesn't seem to be a factor.
Great. Well, we are out of time. Thank you so much. This was really interesting. Something that most of us, me certainly, had never heard of before. For those of you watching, please fill out, there's a QR code there on the screen for the survey. We really appreciate you filling that out. As I said, it helps us a lot. I'd advertise our next grand rounds, but I haven't chosen a topic yet, so stay tuned. You will get an email about it. And in about a week, you'll get a recording of this email. And there are some thank yous in the chat for you. Great presentation, interesting and informative. Yes, great. So thank you very much. And thank you everybody for attending. Have a good rest of your day.
I enjoyed it. See y'all.